right. Well, like I said, welcome everyone to the weekly ARMA COVID-19 virtual town hall. We'd like to thank all of you for taking time out of your evening to join us for what's been another very informative event. Just some quick housekeeping for everyone. This is a professional environment and we ask that everyone remain respectful towards all participants. This webinar is being recorded and will be published for others to view at a later date on ARMA's YouTube channel. You can see and hear us, but we cannot see or hear you. Webinar is best accessed through a computer utilizing the functions on the Zoom screen, such as the Q&A function for submitting any questions throughout tonight's presentation or event in general. And then the best viewing option is to fit it to your window. Tonight's moderators include myself, Damian Johnson, ARMA's Director of Communications, and Megan McCabe, ARMA's Deputy Director of Government Relations. Tonight's guest panelists include Dr. Priya Radhakrishnan, HonorHealth's Chief Academic Officer, and Dr. Guy Reed, Dean of the University of Arizona College of Medicine, Phoenix, Dr. Ross Goldberg, President of the Arizona Medical Association. And at this time, I'm going to go ahead and pass it along to Dr. Goldberg for a quick update from ARMA.
Thanks, Damian. Good evening, everyone, and thank you again to our panelists for participating tonight. It's another week and more things are happening in this state, as you're all aware. We will continue to keep you informed. Obviously, it changes almost day by day at this point, or hour by hour. Again, always feel free to reach out to your leadership about what's going on, how we can help. And that's really much all I want to say. More will be coming, obviously, through further communications as we move forward. I will say the one thing, obviously, you saw with the federal staffing, the contract was signed. So there's some staffing coming in, about 500 people coming from the outside the state to help with some of the hospitalization staffing. Speaking as someone working at one of those hospitals, we greatly appreciate the help. With that, Dr. Radhakrishnan, I'm going to kick it over to you. By all means, floor is yours.
Thank you so much, Dr. Goldberg, and thank you to ARMA for this opportunity. I'm just going to share my screen. Give me a second. Can you guys see my screen yet or no? Are you able to see my screen?
Not yet, no.
All right, I'm sorry. Give me a second. It appears that I have like too many windows open, so give me half a second and there you are. Okay. Are you able to? Now you can see my screen? Are you able to see my screen now?
Looks great.
Yes, we're good. Yep.
All right, perfect. Thank you. Sorry about that. So thank you for this opportunity. As I'm sure all of the physicians here can really talk about, it's been a wild ride. And the GME playbook as we knew it is out of the window. And so I'll try to give a brief description of what our health system has been doing, and also an update on our graduate medical education. And so just a reminder about HonorHealth, we have 5 hospitals, soon to be 6, and we have residency and fellowship programs in most of our hospitals. Our residency programs are listed here, and our fellowships are listed here. We have about over 70 ACGME accredited positions. COVID has definitely caused a pretty significant disruption, starting in March, where we did not know what the disease really did, and did a lot of learning from our colleagues, both in Europe as well as in New York. And we started our process of planning, interestingly, at HonorHealth, the early part of this year, when we had started hearing about COVID and how it was very gradually ascending and moving across until it became pandemic status. And so many of our operations in terms of planning has already started in January, but like most of the hospital systems here in Phoenix, we started feeling the actual impact of COVID-19 around March, and then subsequently really started, felt really good, like we all did in this community, saying that, yes, Arizona had done it and we were great. And then now have gone through this roller coaster of disruption. And, mainly I'm speaking from a graduate medical education perspective. Being a very residency-centric, community-based teaching hospital, we do a lot of teaching for medical students, nursing students. We have over about 900 student rotations a year, and one of the biggest impacts was a hold on a lot of the clerkships, nursing, pharmacy, and across the entire system, particularly when we started seeing a bump in the clerkships. We've been, like all other hospitals, really working on PPE, and, for now, we have been able to maintain our PPE, but, it's all relative when you look at PPE supply. If you look back a year ago, when we would discard all the PPE at each individual patient room, that's changed a lot since the national shortage. Our focus has been on the clinical learning environment, and we really started making sure that the infection control education was really disseminated across the institution. And this is, as you all probably are aware, this is really central to making sure that our employees, staff, residents, attendings all stay safe. And really, from March, had enforced very strict social distancing rules. And what it did was, really required us as an institution, and I'm sure this is, we're not unique, this is across the entire country and the world, had to very rapidly move to virtual learning. And that itself led to some very interesting challenges. If you look at quality improvement and patient safety and root cause analyses, we still continue to learn and really figure out how best, because not only are we dealing with COVID, but we want to make sure we provide the best care. And so, we use WebEx, and like everybody, I'm sure we have our WebEx or Zoom tales to tell. Interesting learning across the organization was that, our trainees actually wanted physical in-person sessions, and that has been across the board. And I think one of the hardest things is really in the middle of the year, switch to virtual learning, and that has been a huge challenge for us. Having said that, I think most of our professional societies and our program directors have done a wonderful job, as well as our faculty, in making sure that we were able to switch on virtual learning almost in a couple of weeks. And like most other institutions, we continue to refine our processes for testing. Testing has been limited, as you're probably well aware. Initially in March, it was very reserved to, people who we were absolutely sure had COVID. And along as more and more testing has been available, we've been really working on offering it to the community, but also really refining and redefining and redefining our processes for our medical staff, as well as our nursing staff and employees, because our goal is to keep all of us safe. Early in March, we had an almost complete shutdown on electives for our graduate medical education, and mainly because of telehealth. Many of the practices were switching to telehealth, and so we were able to absorb our residents into either inpatient ICU or ambulatory areas. And then over time, as things sort of settle down, if you will, we were able to re-engage electives. We did a pretty rapid transition at HonorHealth, and that's one of our incredible successes. And to date, we've done over 90,000 video visits and over 28,000 telephone visits. And we were able to through our IT as well as HonorHealth Medical Group, really switch it on almost overnight. Now, the impact on telehealth on graduate medical education took a lot more of, rapid cycle PDSAs to figure out. One, the initial rulings did not have any mention of residents, and so we had to clarify whether resident visits counted, would we get paid for it, and so on. But then the subsequent rulings did clarify telehealth and graduate medical education, and interestingly, telehealth has been one of the biggest silver linings of this pandemic, and our patients love it, our residents, as well as our doctors, for the most part, really love it. And I think, in terms of advocacy as it relates to ARMA and also many of the other professional societies, I think this is a very important piece. One of the things we are working on, because within our institution, we have a whole big, wide variety of patients from diverse backgrounds, is really access to telehealth, particularly for our vulnerable populations. And so a federally qualified health center working with some of the national initiatives are really looking at how do we support our patients. And I think this is an important area of research and study. Alongside with providing care to patients, we've rolled out our social determinants of health program because, as you probably have seen from all of the literature that's emerging, there are pretty significant disparities in care, COVID or otherwise, and I think this pandemic has given us an opportunity to really address that in a bigger way. The pandemic has taken a huge toll on healthcare across the board, and I don't think I am exaggerating when I say that. As opposed to sort of the original, 4 weeks and we'll be all good, this has been a very constant struggle to make sure that the well-being of our staff is maintained. And so we've done a lot of work at HonorHealth in making sure that we look at well-being from a 360-degree perspective. We had already rolled out Care for the Caregiver program, which was an initiative at HonorHealth to support physician, nurse, and staff burnout. And as you can imagine, burnout, our healthcare, staff, healthcare workers in general have a very high burnout rate, and the pandemic certainly has not helped. And so very quickly, our directors, network directors of Care for the Caregiver, Dr. Ellis and Dr. Sarah Snell, rolled out the physician and staff resource line. And alongside our Human Resources Department really, gave constant feedback, constant access to mental health, and that was pushed out to all of the employees, and a real conversation occurring at every level about how it's important to get mental health counseling. Early in the epidemic, when there was a lot of scarcity of, as we all know now, toilet paper and many other things, all our hospitals converted our cafeterias into mini marts, and they continue to provide some basic supplies, especially because we realize that this, the pandemic is here to stay, and we want to make sure that our residents, staff, and employees don't feel that they have, once they leave the hospital, and now have to go do grocery shopping. We have also rolled out healthy, nutritious meals for $2, and they're available in all of our cafeterias. And alongside COVID came the Black Lives Matter movement, and really realization of how important equity is. And so we have worked within our graduate medical education programs as well as the broader system on diversity, equity, and inclusion. And we've had several listening sessions, and they've been very powerful. And this is, again, like most of us, a work in progress. So I also want to just, talk a little bit about the impact on the workforce. So the ACGME has had different levels of urgency, and we've been sort of following the ACGME guidance pretty closely. ACGME is rolled out bi-weekly, initially weekly and now bi-weekly DIO designated institutional official calls, and really created a sense of community because, we're all in this together, very similar to what you're doing at ARMA. And I think it's really important for us to address the impact on medical education, particularly residency education. And, we're very keenly sort of following our metrics, and no more than, having a virtual graduation and orientation sort of puts that in perspective. And, the virtual graduation was one of the most bittersweet things that we had to do. And we waited pretty much almost till the last minute because we were very hopeful that things would get better, and they didn't. And developing a sense of community when you welcome new residents on their first day and do it virtually is hard. And added to that was the fact that most of our medical students who were now our interns really had no patient contact for about 4 months. And, residency programs have really picked up the education, and some of the learning curves have been pretty steep. And I think it's really important to acknowledge the work that the faculty, residents, and also our staff are doing, keeping in mind the distributed model. Most of us are working from home if we are not clinical, and if we're clinical, we are in the clinics, but making sure that we're careful about social distancing. And so it has taken a pretty strong hit. But, as always, we are really helpful because innovation comes from medical education. And we've had really wonderful programs and pilots all across all of our residency programs, including, research, which has started in full force, really examining COVID, and particularly the clinical focus on COVID. And so just to end, we in medical education are really having our residents, faculty, do a lot of community education, community blitz, as well as awareness, because this pandemic requires a 360-degree partnership with patients, with community, and with everybody. Otherwise, we will not be able to address it. And with that, I want to say thank you, and back to you, Dr. Goldberg.
That's great. Actually, I'll take it back to Damien, let him kind of run things. That was fantastic. As someone who has residents who've gone through the same thing, we appreciate all the work that you went through. It's definitely a learning experience, to say the least. We just started M&Ms again via Zoom, and that's a very interesting experience compared to the 90 of us in a room. It's very different. Damien, all yours.
Thank you, Dr. Radhakrishnan, and thank you, Dr. Goldberg. I just want to remind everybody in the audience, before I kick it over to Dr. Reed, that if you do have any questions, please do submit them in the through the Q&A function. If you have any comments or would like to chat directly with the panelists, you can do so through the chat as well. Dr. Reed?
Thank you. I'll share my screen here, I believe. Okay. Everybody see it? Great. Okay, wonderful. So I wanted to echo a lot of things that Dr. Radhakrishnan said, and really commend her for a lot of leadership, and particularly in the area of graduate medical education and the achievements that she's had, and starting programs and getting commendations for those programs. That is a very tall order. So again, congratulations on that, Priya. You're exactly what we need here in Phoenix. So, so I was asked to spend maybe 5 or 7 minutes talking about how has COVID-19 changed medical education. And I'll make a couple of suggestions, but I look forward to your questions, comments, maybe even your rebuttals. So in a nutshell, it profoundly affected medical education. March 7th, 2020 is a day that will live in infamy at the College of Medicine Phoenix 4.5 months ago, when we completely transitioned to virtual education. We were relatively early in this process, but we realized that these steps were going to be necessary to ensure the safety of our faculty, our staff, community. We sheltered at home. All of our education became virtual, as Priya alluded to, not only education for the first 2 years of medical school, but also for 3rd and 4th year students. We withdrew them from clinical rotations. And we did that in part because we wanted to keep them safe, but we also realized that the country in our area in particular was facing a shortage of PPE. And we were concerned also about interfering with the efficiency and care of delivery for these patients. So we didn't want our students to be an impediment or to be putting anyone's health at risk. So that was one of the reasons that we withdrew them. We started what we call a virtual integrated clinical curriculum for our core rotations. The idea was to teach students the essential things that they need to see in every pediatric patient or every internal medicine patient or every surgical patient, and then to use those virtual learnings to supplement what they would be able to do when they return to clinical rotations. Match day became virtual. This was an area of profound sadness and rejection for our students. I remember announcing this in an auditorium and thinking that I would be crucified for this suggestion, but and we had to do it, and it actually came out really, really well in a creative way. I encourage you to go to our website and look at that. We got to see actually people celebrating their matches with their families, something that was really kind of unprecedented for us. Graduation became virtual. Again, I feel so badly for our class of 2020. They just suffered one setback after another setback. And then the second visit day, which was really important for our medical students to decide where they were really going to finally enter medical student school. I mean, our applicants. Everything became virtual. But our students cared deeply about the community, and they engaged in several activities to try to be of service during the COVID-19 epidemic. 30 new physicians graduated early. We changed the curriculum. We went through all of the requirements. We made it possible for them to graduate early so that they could serve the community in a time of need. Now you see, this is the traditional picture of them marching down Van Buren Street. They couldn't do this anymore. This was virtual. So this is only a memory of what we used to do. We graduated people in their own homes, wearing their own gowns, doing all of those things. An incredible graduation. And then students tried to find ways to help. And they did it by trying to come up with novel ways to create PPE, new ways to protect against aerosolization during intubation, all sorts of creative things. The one thing I do want to point out was their efforts to partner with South Korea to deliver supplies to the Navajo Nation, which has been so severely impacted by COVID-19. Together, they put in 5,300 volunteer hours, more than 6 tons of supplies, food, PPE, 10,000 N95 masks, all delivered to the Navajo Nation in 7 flights with the volunteer efforts of Guardian Air. This just warmed my heart and just, spoke to the fact that these young people want to make a difference in improving health wherever they can do it. We continued on virtually in our goal to improve the health of communities through distinction and personalized medical education, translational research and patient care, all within a culture of inclusive excellence. And we worked on our strategic plan, which really was focusing on inclusive excellence. And many, many things were accomplished. 64 students went to the Latin Medical Students Association, the Students National Medical Association, the Asian Pacific Association of Medical Students, so that each of these students could engage with their own communities to find ways to promote diversity and success in medical school. We had 20 medicine and women in medicine science events. We did a number of faculty development for the AAMC Women and Minority Development Conferences, 50+ diversity trainings throughout our community. And we were recognized by the Higher Education Excellence in Diversity Award for all of these efforts. But something happened, as Priya alluded to. And the killing of George Floyd, I think, emphasized to many in our campus and so many in our community that structural racism is a pervasive issue that also affects public health. And our trainees and our fellows and our residents and our faculty felt very deeply about this. This is a picture, one of many pictures from our residents, our faculty, our fellows around the institution, taking that moment to give reference to the importance of white coats for Black lives and Black Lives Matter. And our students and our new Black Alumni Association members, as well as our students, were very thoughtful about the things that we could do as an institution to try to promote diversity and inclusion and to address these episodes of structural inequity and racism. And we have addressed areas such as compositional diversity, education and research, culture and climate, communications, and developed a plan for 12 action steps to try to make things better in our community and around Phoenix, to make this a less vulnerable area for structural racism, and also to try to eliminate and reduce racism in our area of healthcare. This obviously arose during this COVID-19 pandemic, and you might say that this pandemic has been a pressure test for all of our institutions. It's a real test of what really is not working. When you subject something to pressure, you see where it fails, where it's inadequate. We have seen where our hospital systems have been challenged, our care delivery models have been challenged, our reaction and our inclusion and our diversity and our structural racism have been challenged. So many things have been challenged. Right now, we are challenged in our healthcare system. We have achieved the ignominious distinction of being second in the country for the prevalence of COVID-19. We're right behind New Jersey, and if we keep going, we'll get there. And locally, we have about 1/3 of our hospital beds and 1/2 of our ICU beds dedicated to COVID-19 patients. So this is a real and continuing stress for us. So we had to decide going forward, what's the academic year look like? And we decided, starting June 19th, that we would do a virtual orientation for our new residents. Isn't that a sign of our times, where we're orienting our residents virtually? We welcome back some of our medical students, June 25th and 26th, for clerkship training. Clerkship training, in my mind, is absolutely irreplaceable. You cannot become a physician if you are not involved intimately in one-to-one patient care. We've launched our classes for the class of 2024, July 6th, and we're anticipating that we may return to campus September 28th, 2020, depending on conditions. Of course, why did we pick that date? Well, that's just a date where there's a break in our medical education blocks, so that students can move and do other things if they need to relocate to campus. What's really amazing is that despite these challenges, we are bringing you an outstanding class of medical students for you to educate and inculcate into our profession. We had about 6,100 applicants for now our biggest class, 100 students, 18 states across the country. 57% of the students are female. Last year, I think they were 60% female. The tide has changed, Dr. Goldberg. Academics, our top contributor was Arizona State University, but we get a large contribution, probably altogether the largest contribution from California. These are very talented students of mean MCAT of 514, which puts them in the top 10% of students in the country, top 10% of students. Outstanding GPAs in science, and overall, 25% of them have graduate degrees. And what we're proud of is that 60% of them have score on one or more of our dimensions of diversity. They come from either socioeconomically disadvantaged backgrounds in which the family has been educationally under-resourced, or they are from groups that are underrepresented in medicine, or they come from rural areas. So let me begin to just sum this up and answer the question, how has COVID-19 changed medical education? Well, I think it's demonstrated irrefutably the value of virtual education, both synchronous, that's sort of what we're doing now, and asynchronous. It has also challenged medical school traditions. It used to be believed, and this is, when I was educated in the last century, this is how I was taught, and I think even medical students in the century before this were taught this way. Anatomy, you all just dissect it together. We're not doing that this year. That's not safe. We're looking at new ways of learning. And it's caused us to rethink how we do clinical training. I think we've all come to the conclusion, pretty obvious, but we needed to get there, that in-person clinical training with patients is irreplaceable. It's irreplaceable. And we may have to do it even if there's some risk associated with it, because otherwise students cannot become physicians. But a lot of clinical education may be supplemented or learned virtually, and we're going to proceed with that. Could it be the death knell for the lecture? The lecture has survived for centuries. Could this actually be the end of the lecture? Possibly. And I think it's also revealed that we have to educate ourselves to address structural racism and other areas of inequity if we're really going to improve health for all. We've seen, as Priya alluded to, that there is tremendous inequity in the survival, hospitalization rates, and people of different categories, different groups, different ethnicities. We have to do that. And I also want to say, in a very hopeful note, it's revealed the extraordinary commitment, the creativity, the problem-solving ability of all of our physicians, staff, and students. When that fateful day, March 7th, came and we had to start our virtual curriculum the next day, they did it. It was incredibly impressive. And our students adapted really well. I think COVID-19 has highlighted also the central role that physicians play in the health of our communities. I mean, I think it's brought us as a group front and center to be valued again in a new and important way. I think that I've really been impressed that our physicians continue to treat those in need despite uncertainty about this illness and despite personal risks to themselves and to their families. And I want to say for all of our physician colleagues, all of you on the line today, that we at the College of Medicine are so proud of you, and your work and your dedication has really been inspiring to all of us. So with that, I'll end and be happy to take any questions. President Goldberg.
Thank you, Dr. Reed. We will go ahead and jump into some questions here. One question here is regarding ACGME's response and flexibility, and what the boards for ABMS, the specialties have strict procedural, surgical, clinical case minimums for residents to graduate. Is there any word on how flexible they will be?
So, as we were approaching graduation, and luckily Arizona did not feel the impact until sort of graduation was at our doorstep. And so while there were some major disruptions, as you recall, particularly in the surgical specialties, to prevent the pandemic from rolling into our backyard, many of the hospital systems opted to reduce surgical volume so that they would increase capacity. And then once we felt that things were contained, we had hoped that that trajectory would continue. So surgical and interventional procedures have sort of gone on and off just based on the volume and the need for ICU beds. Currently most of our systems have again ramped down except for emergency. And so for the graduating class, ACGME actually gave program directors a lot of leeway in terms of certifying their eligibility and competence. And particularly our procedural programs really did not have as much of an impact. But as the pandemic sort of goes now into the whole year, we will definitely see significant changes, and each RRC is different. And so, for example, the impact of closing a pediatrics unit will have an impact on family medicine, for example. And so one of the things that we are doing as a health system is really making sure that we keep close watch, and ACGME does allow you to invoke the emergency status for accreditation, and that sort of gives you 30 days to regroup, if you will. ABMS is still evolving, and so ABMS just recently rolled out their recommendations for vacation. And so, for example, if residents were either impacted by COVID or took time off for personal reasons, maybe maternal health, then they are starting to leave it to the individual specialties. And I think here's where a lot of advocacy is important. And like Dr. Reed had mentioned, we really have converted almost 100% to virtual learning. And this is our opportunity for innovation and to really do rapid cycle PDSA in medical education to see what works and what doesn't. Our residents have done such incredible things like, designing entrance to clinics so that you could get tested. I mean, all the way to designing masks and things like that. And so I think the science of healthcare delivery as well as competency has kind of gone on its belly, and we are back to sort of redesign and really assessing competency. I suspect virtual platforms will have a lot of competency through virtual design is going to be important.
Damien, actually, if I could jump in too, from the surgical side, talking to the American Board of Surgery, we're a very procedure-based, profession, right? We have numbers we have to reach. We have minimum numbers we're supposed to be hitting. So we were fortunate, at least we're in this hit regarding, if our chiefs needed a lot of numbers by March, we had a problem. They had 5 years to get them. But what do you do going forward? And there was a lot of discussion about, well, do you really not change the numbers? Do you still say you need to get them? Or if you're going into fellowship, it's very interesting. I'm laughing because even the boards themselves. So my chiefs were roaming around our offices recently because they're taking their boards this week, and now it's going to be all on a computer with a camera monitoring them. Like, if the office had too much stuff in it, they weren't allowed to use the office. Like, I think they're going to have like proctors watching them through the cameras. It's the weirdest thing I've ever seen in my life, but it's really amazing to show how adaptive these boards are being to try to make sure that they don't disrupt the normal flow, because I have to adapt. We don't know when this is going to end. It's a very interesting world to live in right now.
Before we jump to the next question, I just want to make sure, Dr. Reed, did you want to jump in, or should we move to the next one? I think you're muted, sir.
Priya did a masterful job answering that one. So.
Perfect. So the next question, the attendee asked, what can ARMA and other organizations like us do to encourage more physicians to get involved in precepting or integrating medical pre-clerkship students into telehealth outreaches for things like mental health screening, et cetera? The goal would be to help patient population management across healthcare systems.
So maybe I'll start with that one. So just call me, look me up. We'll be happy to find a way for you to get involved. I have to tell you, people who teach medical students feel rejuvenated, inspired. You know, they feel like they have a second life. So I think that they should be paying us. But it's really an extraordinary thing. So Russ, I know is being skeptical there, but I have to tell you, it's really an incredible experience, and we'd be happy to help you with that.
If I can add, I think from an organization that is predominantly focused on graduate medical education, we do feel the severe loss of medical students, and I think in sort of the next wave as this pandemic continues, we will be looking at a multiplicity of different options for medical students, both virtually as well as in person. I think some of the decisions are really focused on PPE, which is one, and I think most of the medical schools have done a pretty good job in really helping, at least our organization, with getting PPE if we need it. And the second is, again, really looking at virtual learning and collaborative learning. I think this is the time to really test some of those and developing curricula. I know most of our programs are working on telehealth curricula, but I do want to reemphasize that there's there's nothing that compares to having a live patient talk to you and feeling through palpation and going through those steps. But I think the COVID pandemic actually has probably hastened the development of the tricorder. For those of you who are Star Trek fans, you know what I'm talking about.
I just wanted to say one quick thing. Any of our physicians who are physicians of color or from groups that are underrepresented in medicine, we would be particularly welcoming to have you get engaged with the college to help our students who are from underrepresented groups feel part of a larger community. And for you to mentor them and do other things like that. So we particularly welcome that. So thank you.
Great, thank you both for those responses. It looks like we have a question in the chat here, and I just want to remind the audience too, if you do have any questions while we have some time left here in the hour, please feel free to submit them through the Q&A function, and we will definitely try to get to them here. One of the questions, I believe this is for you, Dr. Reed. How are you teaching anatomy if not with a cadaver? I know you mentioned that towards the end of your presentation there.
So there is software and virtual reality software that will help with visualizing and doing virtual dissections and helping people understand the three-dimensional relationships of organs to other organs and other tissues and muscles to bones and everything else. But so our group has been an award-winning cadaver-based teaching group, and they have made the pivot, and they're using virtual software, and they're also doing this both in a kind of a synchronous way. So they will engage you like we're engaging now, but also go back and forth with the software and do this virtually. It's really an extraordinary kind of a deal. And so what we are thinking also is that for those who are inclined towards surgery or other things where you may need to have a deeper knowledge of anatomy and the relationships, three-dimensional relationships and other things and variations and human anatomy, that we will have an elective in fourth year for those who are going into those specialties, which might be cadaver-based to supplement it. I know that Dr. Goldberg looks like he wants to sign up for that, I think.
Sure, count me in.
Great, thank you, Dr. Reed. Actually, I believe Dr. Goldberg has a question for our guest panelist.
Yes, and it's partially selfish, I'll fully admit it. The reason is that, and I think this is an important one to bring up, is that as we've integrated the medical students back into our rotations, we're running into, and it's obvious what time has done, has truncated a lot of the early rotations, right? So instead of a 3 or 4 week rotation, some are getting 2 week rotations. So what are your recommendations to us as not just educators, but as evaluators? Because 2 weeks is not a lot of time to really evaluate someone potential. You know, I joke on our general surgery service, the first week is pure chaos for them. They have to figure out, you know, which way is anything. And we use that as a wash, as we don't hold it against them if they don't know what's going on. But if you have such a short period of time, what is your advice to us on how we can best maximize our ability to evaluate and provide a beneficial rotation for the truncated period for these students?
I could start with that. I think that's a real challenge, and we appreciate it. You know, I did a lot of attending for many, many years, and I agree with you. It wasn't really until maybe the middle of the first week that I really began to get a sense of the students' capabilities. I think you just have to ask them to step forward earlier. You know, there's a natural reluctance or reticence for students when they first start off. But I think you have to say, look, we have a limited time here. I want you to step forward. I want you to engage. I want to see what you know so I can help you with the things that you don't know. I think, and just actually engage them in a very direct way. We realize there are limitations to this. Our concern is that the way things are going, we may have another stay-at-home order. We may have a PPE shortage. We're coming to the flu season, God forbid, where we not only have COVID-19, but we have the flu filling our ICUs and hospitals. And so we want to give everyone a couple weeks with great physicians to get what they can. And then if we have more time in the year, I think we'll be more flexible.
I think that's great. I mean, just to follow up too, I would argue also is that for the students especially, this is a huge learning opportunity just seeing this.
Yes.
Even from, if we don't let them go in the COVID rooms, obviously, but just what entails and what not to do maybe going forward. Because unfortunately, the way things are going, I think they'll have to deal with another pandemic in their lifetime. So I think this has been invaluable stuff. So we appreciate having those students back. Believe it or not, it was weird not having them around.
I love to hear that.
I'd agree. I think the one thing I will add is I think both undergraduate and graduate medical education needs a real hard look at what competence means. And you know, I mean, I love the U of A primary care program where you truncate the medical school for people who know what they're interested in and really are able to develop that pathway. And I think this pandemic may actually accelerate that innovation. You know, I have said forever that, you know, 4 years plus 4 years plus 3 or 4 or 5 years it doesn't always make the same doctor, especially if you look at, you know, across the pond where, and many areas where, you know, people go directly into medical school. So I think this is an opportunity to really relook at medical education across the board.
Really interesting. Thank you both. Next question from one of our attendees is, residents in New York City publicly discuss their concerns about working with inadequate PPE during the peak in New York. And many are concerned that our resident unions here in Arizona raising that issue with you.
So I can start, you know, at least at our organization, we actually have a very transparent system within our health system. If you just go into our intranet, you know exactly how much PPE we have. And that was done very intentionally to make sure that everybody knew, and then we're all in it together. So we want to make sure we are able to conserve, and that's the reality of the ground today. I think, ARMA and ACP and all of the other professional organizations really do need to continue our federal and state governments to help the healthcare providers get PPE. I think it is essential. And, our voices really, this is a time for physician leadership, medical students, all of the physician community to really jointly talk about how hard it is to take care of patients and what we need our community and our elected officials to do.
Great, thank you, Dr. Radhakrishnan. And there's a follow-up question to that as well. Are you familiar with any resident unions in Arizona?
I am not.
Okay.
I will say,
then we have.
I can say, Damien, I was part of a union in New York when we actually formed the union while I was in my hospital. That takes a significant amount of effort and time. And so you would be aware of it if it was going on, trust me.
Great, thank you, Dr. Goldberg. Looks like we have one more question here that we can kind of close out with. Any thoughts on eliminating the MCATs as a prerequisite for admission to medical school?
I think Dr. Krishnan wanted to answer that one. Radhakrishnan?
So all yours, Guy.
Okay, well, thank you. Thank you very much. So here's the challenge. We have anywhere from 70 to 80 students applying for every position. And they come from, hundreds of schools across the country. And all of those schools have different grading standards, different selectivity. And so there is no leavening way to understand the value of those grades except a standardized test. Now, a standardized test is not the be-all and end-all for getting into medical school. It's just one measure. And it's only one measure in our admissions process, which is holistic. We also have a program that is specifically designed to give students who come from diverse backgrounds whose MCATs are not good, the opportunity to have a year in a Pathway Scholars Program to prepare for medical school. At the end of the year, if they have to get a certain level in their MCATs and they have to pass a certain level in their tests, but they will be eligible for entering medical school. That is our antidote, if you will, to just a standard metrics-based admission system. We also spend an enormous amount of time and effort on evaluating our students for their personal characteristics, their commitment to service, their ability to work with other people and understand people from different backgrounds. That's called a mini interview process in which they're subjected to all sorts of different simulations. It's an intensive process. We have people from the community come in and help us with that. So we try in every way that we can to choose the students who are best suited to become physicians and serve a lifetime in their community to promote health. MCAT is only one piece of it, but it is an important way to look at them, a complementary way.
Thank you, Dr. Reed. Before I close out here, Dr. Radhakrishnan, did you have anything that you wanted to add to that?
No, I think we are going to be seeing the impact of USMLE Step 1 scores being eliminated and looking to see what happens with Step 2. You know, Guy, you had mentioned you have about 80 students in specialties like internal medicine and family medicine. I think the ratio is almost up several thousands of applications as well. So, yeah, you know, unfortunately, there's no other metric, and it's going to be hard to determine, you know, who are the great candidates. So it's going to be a challenge for all of us.
Great. Well, I want to thank you both, as well as all of our attendees tonight for joining us. This has been a very informative evening, and we appreciate both of you taking time out of your evening to join us. Just as a reminder to all of the attendees that this town hall was recorded and will be published on ARMA's YouTube channel. If you have any further questions or concerns or would like to be connected to Dr. Radhakrishnan or Dr. Reed, feel free to email us at communications@azmed.org. And then just a quick reminder as well that resources are available to you, the physician community, on ARMA's website at azmed.org. You can find telemedicine resources, COVID-19 resources, FAQs, as well as financial resources related to COVID-19. So I'd like to thank you all again for joining us and hope you have a lovely evening.
Bye-bye.
Bye-bye. Thank you.